Hi, I'm Tamara Paget, and this is case study number 8, peripheral arterial disease, otherwise known as PAD. This is for class Nurse 711, Advanced Physiology and Pathophysiology, and this is November 26th, 2024. The patient is RB. She's a 52-year-old female. She has a 40-year-old history of diabetes type 1. She walked to a local supermarket and developed a small blister on her foot. And then a few days later, she realized it had gotten worse, and it developed into a large open wound that was black and blue color. For the next 2 days, she cleansed it, covered it with sterile gauze, but the wound didn't get any better. In fact, it became progressively worse and painful. So her son urged her to seek medical attention. 5 days after the initial injury, she had her appointment with her primary care provider. And at that time, there was a significant amount of necrotic tissue and exudate, and there was a lack of pink granulation tissue in that wound. So this patient has peripheral arterial disease, which is a vascular disorder. There's structural narrowing of the blood vessel outside of the heart or the brain. And this structural narrowing is caused by a buildup of cholesterol, scar tissue, or calcium, otherwise known as atherosclerosis. And it can decrease the blood flow to the dependent areas. This poor blood flow causes injury to nerves and to the surrounding tissue, and this is prevalent in about 12 to 20% of Americans aged 65 and over, and as a person ages, their risk factor increases, and it is also more common in men. Diabetes and smoking are two of the biggest additional risk factors other than aging for peripheral arterial disease. The pathophysiology of PAD is that, as previously discussed, there's a buildup in the walls of the arterioles, and the vessels become stiff, less elastic, more narrow. This narrowing can progress to total occlusion, and the arteries in the legs cannot dilate to allow for extra blood flow, especially when needed, such as exercise or infection, which is what is happening with our patient. The reduced blood flow also results in thinning of the skin, reduced muscle mass, and tissue necrosis can develop. Diabetes leads to PAD due to an abnormal lipid metabolism, so there's increased buildup of lipids in those vessels. The diagnosis for PAD is based on the 7 Ps: pulselessness, paralysis, paresthesia, pain, pallor of the skin, and polar skin, which is cold skin. They just, I think, call it polar to make it another P. And then pressure, which is less than it's less in that limb than in the arms. So although RB has been dependent on insulin since the age of 12, she's enjoyed a relatively good health. She's been careful about her diet and exercise and keeps her blood sugar stable. However, she does have high blood pressure for the last 4 years, though it has been controlled with a thiazide diuretic. That is the only medication that was mentioned, and also no additional history, family history, or allergies. She doesn't smoke or rarely drinks. For the pallor test, she did have level 3 pallor in her right lower extremity and level 1 pallor in the left lower extremity. She had ankle brachial test, which you can see the results there, which are significantly different than her systolic pressure in her arm, which was 130. She does have a history of intermittent bilateral calcification, and her right dorsalis pedis artery and right posterior tibial artery pulses were not palpable. She had a slight fever of 99.8, which probably points to an infection, and both feet were cool to the touch, and her toes on her right foot were slightly cyanotic. Her lab work did show elevated glucose, actually significantly elevated. It was fasting, and her glucose was 210. Her LDL was 162, HDL of 26, total cholesterol of 291, white blood cells of 11,900, and neutrophils 80%, which points to definitely an infection and increased cholesterol levels. This lady, after cultures came back, was treated with antibiotics. Cultures were obtained, antibiotics were started. Once the culture and sensitivity came back, she was switched to a gram antibiotic that was more specific for gram gram-positive bacteria, and her right tibial artery did show an obstruction in an MRI. The role of the advanced practice nurse for this patient is support, education, and medication management. So educating her on how to relieve the symptoms of peripheral arterial disease and self-care, along with possible starting of medication and possibly using ginkgo biloba and aspirin. Also, if the patient is willing to participate in peripheral support, that would be definitely in line with the practitioner and the patient's belief would be great. And the practitioner can always offer the reassurance of Psalms 46, 1 through 2, which says, God is our refuge and our strength, our ever-present help in trouble. Therefore we will not fear, though the earth gives way and the mountains fall into the heart of the sea. Questions to consider for this patient is, why is it unlikely that a thrombus or embolus contribute to the arterial obstruction in this case? Secondly, what are the most serious complications that can develop from peripheral arterial disease? And lastly, what conclusions can be drawn from the pallor and the angular brachial test results? And here are my references. Thank you very much, and I hope you have enjoyed and learned something from this presentation.